Very good. Okay, Assalamu alaikum. I am Ibraheem Masoud, fifth year medical student, and I will be teaching you about one of, well, I would say, an underrated topic. It's one of the most underrated topics. The reason why I say this, because it's actually very fun and simple to understand if you approach it with the right, let's say, direction. So if you go with the right direction now with me and with the lecture, you will find out that it's actually very simple, very fun, and I just have a deep passion for acid base. And I think, or I believe that you guys are the batch I taught maybe 2 or 3 years ago and during pre-med. I think 3 years ago during pre-med, and I also taught you acid base, but it was for first years. Yes, so some of you might remember the first lecture. So I really like this lecture because I believe it can be simplified and everyone can enjoy it just how much I enjoy it and how much I love it. So buckle up. We will go through a very nice journey, very beautiful journey. I would really like if you were interactive, just so I can know which points you want me to repeat, which points you want me to go over more than other points. So in this lecture, I will talk to you about what you need to know in electrolyte disturbance and acid-base balance, not only for your renal block, because frankly speaking, for your renal block, you maybe need 2 slides and you will be good. Because I remember on our renal exam, so don't be scared. This is actually very good news for most of the people. For me, it was bad news because for me, any question from this lecture is a free mark. So actually, our question had maybe 1 or 0 questions about acid base and very, very few from electrolyte disturbance. And if he got, the doctor, if he got a question about them, it usually is a very simple question that everyone can answer. So this is the good news, that for your renal block, you will not need to know this much. You will not need to know everything I'm about to say. It's really much more simpler than you imagine for your renal block, because the doctor is nice. He will get you a very easy question, maybe repeated, maybe even not even a single question. So pathology is your main bulk of the exam for renal. So I'm not only here for renal block, but also for step 1. I studied the electrolyte disturbances and acid-base balance for step 1. It's also not very complicated. They ask almost direct questions, and it's very easy to also digest and dissect once you understand the concept. So you will become an expert. This is a promise. You will become an expert in this, or maybe not an expert, but you will have an exceptional understanding of this topic, and you will be able to explain it to almost everyone. Let's start. That was a long intro, so let's start. Bismillah ar-Rahman ar-Rahim. Wassalatu wassalam ala Sayyidina Muhammad. This is a nice dua I like to start with before explaining anything. Allahumma la ilma lana illa ma 'allamtana innaka anta al-alim al-hakim. Allahumma 'allimna ma yanfa'una wa anfa'na bima 'allamtana wa zidna ilma. Amin ya Rabb. I couldn't find a translation in English, so either Google Translate it or it just means I'm praying to God. It's like I'm giving glory to God about that He gives us knowledge, and I'm asking Him for more knowledge and useful knowledge. This is a very simple translation. So today's objectives, we will talk all about electrolytes, even acid base. By the way, acid base are technically electrolytes. So we will talk about sodium and potassium, and then we'll talk about hydrogen and bicarbonate. So hydrogen is the acid and bicarbonate is the base. So imagine all of this is only for 4 ions, subhanallah. All of this fuss, all of this lecture, all of this information and knowledge is only for 4 ions. So we will talk about them. They're very important and very crucial. So Bismillah, let's start with sodium. As you know, it's found in salt. This is not very important now, but it's important to know, don't eat too much salt. And you will see now why. Not because of hyponatremia, because of hypernatremia. But let's look. This will be the structure of my lecture. I changed the structure of the doctor's lecture, so he had different structure, but I will give you the important information, inshallah. So we'll go over the definition, etiology, and then clinical features and treatment. First things first, hyponatremia. What is hyponatremia? Simple answer. Hyponatremia is basically less sodium than the normal level. So normally we have 136 to 145 MEQ/liter. I don't care what this unit is, just know the number. It's less than 135. And there is something I want you to know before we dive deep into the lecture. This is like maybe high school knowledge. Do you guys know what osmolality is? So osmolality basically is how much solutes is in solvent. So solvent, imagine, is water, and solutes are all the salts, glucose, proteins, lipids, urea. So all of these are solutes, and the solvent, which is the container in our plasma, is what? Water. It's mainly water. So how much of those solutes are dissolved in this water, right? This is, we call, what we call it, osmolarity. And why is it important? Because we know that the osmolarity normally is about 300 in our blood vessel and in our intracellular space. So if it goes higher than that, that's hyperosmolar or hypertonic, means it's concentrated with solutes. And if it goes below that, that's hypotonic or hypoosmolar. We will see. But this is just, I'm explaining the lingo. I'm not explaining anything crazy. This is the lingo from 10th grade or high school. You took it, you know what this means. And at any point, if you found that there is something you don't know, please stop me. Do not hesitate. We want to build a nice connection between me and you guys, so you can ask me anything during the lecture. Okay? Feel free to do so, please. No shame in that. So this is the definition. We have less sodium concentration. Okay, this is where it gets fun. Like, how did you go from here to here? Now, at first glance, this might look complicated, but it's actually not complicated. It's very simple. So the first one on the left, I want you to talk with me now. Okay, talk to me, sorry. Speak. So the first one on the left, it has sodium inside a container. This is what? Is it hyponatremia, or normal? Now, obviously, because it's on the left and it's alone, it's normal. It's normal. Good? Yes, it's normal. Good, good. So you know it's normal. That's something good. Now, that's not why I'm asking you this. What about the one on the right? So the first one from the right one, so there are three. I want number one. What is this? Hypo or hypernatremia? Hypo, yes, hypo. Why do you say hypo? Because notice here, there is this much, yes, there is this much sodium in more water. So now the sodium is more diluted. So diluted is the hypo. Concentrated is the hyper. So here it's diluted, which means it's hypo. Now, just to let you know what's the difference between the dark blue and the light blue. The dark blue is the extracellular fluid and the light blue is the intracellular fluid. So we see that the total fluid changed in number one, hyponatremia. What about number two? And it's tricky. What about number two? It has more glucose. Sodium is the same. The total water is the same, the total fluid. Okay, so you said hyper. Do you see more sodium concentration in that one? So it's actually, it's called pseudo hyponatremia. Why? Because what's happening here? Glucose, notice the difference between, let me put just the laser pointer, 1 second. Okay, this is good. You see this one? Notice how the water went out from the intracellular space to the extracellular space. And what happened now? It is tricking us into thinking, so when we take labs, we will find sodium is 130. So it's tricking us into thinking that there is actually dilution, but it's not dilution because there is no more overall water. It's just shifting of water from one space to another. So it diluted now the sodium in that space, and we think it's hyponatremia. So in reality, the reason why this water is now shifting is because of glucose. Glucose is osmotic, or glucose pulls water with it. You know this. And glucose pull the water and trick you into thinking that it's diluted. So in reality, this pseudo hyponatremia could be actually hyper or normal. So you said hyponatremia, it could be maybe in some situations in diabetes after the patient gets dehydrated severely. So after he gets dehydrated, maybe after uncontrolled diabetes after a long time, he will keep drinking water. The water will keep washing out and leaving, and then maybe it will become more concentrated because he's losing so much water to the glucose. So the glucose is pulling the water out, and this can cause hypernatremia, but we'll come to it later. So this is pseudo hypo, right? It's tricky. And the last one is a hyponatremia because it's also clear. I removed a sodium molecule. But in the last scenario, the difference between the first one and the last one is that the first one has more water. And the last one has less water and less salt. So the last one, maybe someone had vomiting, diarrhea, or bleeding. So water and salt will leave together. And this is hyponatremia. But in the first one, the sodium did not really change, but we added water to this body. So maybe because of cardiac failure, we'll come to the etiology. But do you understand this? If yes, let's take it to the next step. Very good. The next step is this. The tonicity or the osmolality. You remember when I told you isoosmolar and there is hypoosmolar, hyperosmolar, or isotonic, hypotonic, hypertonic? Basically, 1 and 3, the true focus, true hyponatremia is hypotonic. What does hypotonic mean? Hypotonic mean the solutes decreased or the solvent, which is the water, increased. So it became less concentrated. Less concentrated means hypotonic. So in number 1, when we added more water, it became less concentrated. That's hypotonic. In number 3, we also removed water with the salt. But because we removed more salt due to vomiting or diarrhea or whatever, it became also hypotonic. The middle is iso or hypertonic because of glucose. So glucose can pull water, make it isotonic, or can even, when glucose leaves, it will take the water with it, so it can become hypertonic, more concentrated because of so much glucose. So in glucose, it's tricky. It depends on the levels of glucose, but it's basically on the iso or higher side. So the true hyponatremia is hypotonic hyponatremia. Now we understand. This is the true. So now we will be working with the hypotonic hyponatremia only from now on. Okay? From now on, we will be working with the hypotonic part of the hyponatremia because this is the true hyponatremia. This is the true problem in sodium. Now let's take this to the next step. What's the difference between 1 and 3? Before I go to the next slide, let me see your focus or your brilliance, mashallah. The difference between 1 and 3, what's the difference? Just observe, don't overthink it. Just look at it. Water volume, mashallah. Yes, water volume. Just look at it, don't overthink it. 1 has more water, 3 has less water, but they are both hypotonic. So both are hyponatremia, but 1 is hypervolemic and 1 is hypovolemic. Now, I want to introduce you to a new friend, which is, that friend is eovolemic. Eo means the same, or iso. Iso or eo means the same. Someone is drawing, guys. Please don't draw. How can I remove this? No, it's just one line. So hypervolemic is basically more water. Hypovolemic, less water. In euvolemic, what's happening is you're losing sodium without losing water. And I will come to how this happens in a bit. Let's go here. Okay. Let me remove this line. Yeah. Okay. So let me start drawing. I like to draw. This is not what I wanted to draw, but let's say I'm drawing this. This is the blood vessel. You see the 2 lines? So what I'm trying to draw is this. Oh, what is this? What I'm trying to draw is this. Plasma, and then there's intracellular fluid and interstitial fluid. So I will draw it here just for the sake of visuals. And I will say that this is the ICF. This is the plasma. Okay. So let's just put a rectangle here for ICF. And between them in the interstitium or the interstitial fluid. Okay. Now, what I will do is I will explain to you how different etiologies influence the sodium levels. Is that clear what I'm trying to do? And how we said we can have hyponatremia, okay, with high water volume, or instead of high, let me just write increased water volume, just to make it more clear, or same water volume, so we can lose sodium, okay, you can see it here, so we can lose sodium on the same water volume, or when the water volume is higher, or when the water volume is lower. How is this possible? How come? I will explain to you how different etiologies influence the sodium level and the water level. So you can see the whole thing here, okay? I'm drawing from my device. You can see it on the screen. So first thing first, let's start with a disease. Let's choose a disease that can cause hyponatremia and see how it influences the sodium and the water. Let's start with a disease that causes increased volume or hypervolemia. Okay, volemia. Can someone give me an example of a disease that can cause hypervolemia? Any example? CHF. CHF. What's CHF? Heart failure. It's basically congestive heart failure. So let's take CHF for example and explain what happens in it. So in CHF, this is the heart. Okay, this doesn't look like a heart, but whatever. This is a heart. It's right here. See it? And it's failing. So I'll put a little X because it's failing to pump what? Blood. So this is the artery, and this is the vein. The congestion is at the vein level. So the water here is increasing. Not the water here is increasing. So here in that little part, there is increase H2O because why? Because it's stuck. Do you agree? The heart is failing to pump it out. So the water here is decreased. Decrease H2O. Decrease H2O. So what happens in our body, brain and kidneys, when H2O is decreased? Two reactions. I'll tell you what are the reactions. Reaction number one, from our what? Brain. So you know all about the carotid sinus and the carotid arch, how they sense the blood pressure. So blood pressure will go down. This is BP because of no cardiac output. So no cardiac output is the first thing. Then blood pressure goes down. And because blood pressure goes down, what happens? Our brain secretes. Have you heard of vasopressin or ADH? Yes. Vasopressin, what does vasopressin do? Retain more water. So vasopressin will go to what? Increase H2O reabsorption. I'll just write reabsorption. Okay? You agree? If at any step you don't agree with me, tell me. So because there is no cardiac output, there is no high blood pressure, so vasopressin will do what? Get more water from the kidneys. So ADH or vasopressin. In addition to that, the kidneys are not receiving blood. So less renal flow, or there is no blood reaching the kidneys. What will that do? That will increase. Have you ever heard of the RAS system? Of course you have, because you're taking renal. If you haven't heard of the RAS system, we will stop the whole lecture. RAS system is very important. Renin, angiotensin, you know it. So this system, aldosterone, what will aldosterone do? Ultimately, increase sodium and increase H2O reabsorption. So far clear? So far clear. Now, as a result of this change, what change I'm talking about? As a result of getting more fluid, what happens? Let's zoom in at the level of the plasma and ICF. You see here? I'm going to draw here now. Let's zoom in. I'm going to change the color and see what happens at the little level, at the capillary level or the small arterial level. So now there is so much water in the plasma. And this water, so here, this water is H2O. So there's so much water. And there is a little bit of sodium. You see the reabsorption here? There is two factors, two hormones getting water back, but only one getting sodium back. So this water will dilute or concentrate the sodium. What will it do? If you keep getting water, and it's not moving, and you keep getting water, dilute. Thank you, dilute. So now it will dilute the plasma, and then that causes hyponatremia. Congratulations. Now we have so much water. So that is what type of hyponatremia is this? This is the one. It's hypervolemic. Now let's talk about the sisters and brothers of congestive heart failure. Like what? What also similar etiologies cause increased fluid? Those two etiologies are, another one is liver cirrhosis, for example. And liver cirrhosis actually has two mechanisms. Yes, liver failure has two mechanisms. I will draw it here. So basically what happens, the first mechanism is similar. The first mechanism, liver fail, congestion. You know why congestion? Because of cirrhosis. So the cardiac venous return will decrease. Do you agree with me? Venous return will decrease. I agree. Venous return will decrease. So venous return will decrease. That will do what? That will decrease the cardiac output. Same process. So venous return decrease because it's stuck at the liver, and the liver is blocking the return to the heart. So the heart is not pumping enough blood. So there is decreased cardiac output, decreased blood pressure, increased VP, increased H2O absorption. The kidneys are not receiving blood, increased aldosterone, increased sodium, and water absorption. It will do the same thing. In addition to that mechanism, remember that liver, it synthesizes albumin. Albumin is a major protein. And what happens when albumin in the blood, in the plasma, is decreased? So decreased albumin. What happens? Water, I'll tell you what happens. Water will start escaping. So there will be decrease. Yes, oncotic pressure will decrease. So water will escape from the vessel to the ICF or interstitial fluid. That's why they get edema. That's why they get ascites, because the water is escaping. And what happens when the water escapes and decreases? Again, same process, ladies and gentlemen. When the water escapes and there is no oncotic pressure to hold the water in place, again, that decreases the blood pressure and the cardiac output, and the same process all over again. Who else has this mechanism? Let's talk about our dear friend, and this is the one you're taking, nephrotic syndrome. Nephrotic syndrome. What's nephrotic syndrome doing? So in nephrotic syndrome, because in the nephrotic syndrome, what's happening? The albumin, yes, it's going to the urine. So there is decreased albumin. Decreased albumin. And what did we say about decreased albumin? See in red here, what did we say about decreased albumin? It makes the water escape, decrease oncotic pressure, so the water will fill the ICF and the interstitial fluid, and that in turn will do what, my friends, ladies and gentlemen, that will do what? Look at that. This is beautiful. That will also do the same thing. Water is escaping, so there is no enough water or blood or plasma. Blood pressure is lower, cardiac output is lower, and the same thing all over again, aldosterone and ADH or vasopressin. All of these three are what, my friends? All of these are hypervolemic hyponatremia. That's how they happen. Is this good? This is good. This is good. Let's take, first of all, before we move on to the next step, is this clear? Very good. Very good. I love it. Very good. Let's take, do you want to screenshot this? It's not very nice to study from, but I will screenshot it myself, just in case someone asks me for it. If the water leaves the blood vessel, how will it cause hyponatremia? So that's a very brilliant question. Here, my friend, what happens is water will leave the blood vessel, right? And then what happens next? There is no more space for the water to escape to. So imagine you have two containers. Container one has water, you fill container two. Once container two is full, you can't fill it more. And this is what happens in patients with hyponatremia, or sorry, like nephrotic and liver failure. They have no protein, and you've noticed that their ICF, interstitial fluid, is full. That's why they have edema. That's why they have ascites. That's why they have their legs are swollen. All of this because the interstitial space is filled with fluid. So the water, even though it's trying to escape the vessels, it can't. It's stuck. and it's diluting the sodium. So there's so much water enough for it to dilute the sodium. And yes, renal perfusion keeps decreasing, it's not increasing, and it keeps getting RAS. So it's like a vicious cycle. It keeps getting more water. Suffocates. That's why it's very bad. That's why we should act quickly, give them protein, solve the underlying cause so that it doesn't get worse to the point that they get pulmonary edema and stop breathing. They literally can drown in their own body water. See, that's how bad it is. So, you're welcome. So this is for hypervolemic hyponatremia. We understand. Now, anyone in this world, anyone will challenge you, will be like, hey, sir, please explain to me how we have hypervolemia and hyponatremia. And you will explain to him this. Very nice. Let's go to the easier one is actually the decreased water volume. Decreased water volume is pretty self-explanatory. Like it's basically just you lose water. So you lose water, and you lose sodium with it. So this happens when this could happen when the kidneys are failing, because what is the kidneys function? Reabsorb water, reabsorb sodium. If they fail to reabsorb, they will not reabsorb. It will all go to waste. So it will waste all the sodium, it will waste all the water. Or if someone has a burn injury, he will lose all the sodium, he will lose all the water. Or if someone, I don't know, maybe has diarrhea, secretory diarrhea, he's losing electrolytes, he's losing water. Vomiting, he's losing water, electrolytes. This is very basic, very simple, right? It's just you're losing everything, basically. And it becomes hypovolemia, hyponatremia. Now, so in hypovolemia, hyponatremia, you should give them fluids. But in hypervolemia, hyponatremia, you don't give them fluids. Fluids will kill them. You should treat the underlying cause. Treat the underlying cause. Okay. Now, finally, and it's a little bit tricky in eovolemic. So this is eovolemic or eovolemic. Don't mind the pronunciation. In eovolemic, I will take a step forward and just write it here in eovolemic. Okay, this is the title of what I'm going to explain now. So it's actually very little diseases, and the most common disease that cause eovolemic hyponatremia is symptom of inappropriate ADH. So basically, we have increased ADH. Now, you might be wondering, and you are so smart, by the way, I respect you for this. You are probably wondering, why, if we have increased ADH, why is there not hypervolemia? Because ADH absorb water. So what's happening here, there is high ADH, and this ADH, it absorbs water. So rotary up. And this dilutes the sodium. So dilute hyponatremia. And you are smart for this, by the way. I respect it again. But what's happening here, we forgot our friend. Who is our dear friend that acts so much in the kidney? Aldosterone. Welcome back, brother. But this time he's a good guy. He's not acting. So aldosterone is not doing anything. Aldosterone is actually inhibited. So aldosterone, what does it normally do? Normally, it does what? It increases water reabsorption and sodium reabsorption. So you see the problem here, right? You can already, foreshadow what's happening. So here we are, one of them. So this is reabsorbing water because there's a problem. Inappropriate ADH, literally. So the hormone is going out without the need. But aldosterone, our dear friend, is getting sacrificed and it's getting inhibited by the kidneys. It's telling it, do not absorb more water. We have more water. But that's the problem, my friend. Aldosterone acts mainly on sodium. So there is no sodium absorption. And this is the main problem. This is why there's hyponatremia. First of all, because of the dilution. Second of all, because aldosterone is inhibited. So you stop the water and you stop the sodium. So here, who is really losing the sodium? The sodium is getting sacrificed for the water to stay stable. Did you get it? Did you get it? So in this one, there is ADH and aldosterone working together to get water and sodium, but it's too much water, it's getting diluted. In this one symptom of inappropriate ADH, the ADH is acting alone, getting water, diluting, and the aldosterone is like, I can't do anything, man. If I get sodium, I'm in trouble. So sodium, goodbye, brother. We need the volume to stay the same. And this is actually what happens. So now that we explained all the etiology, we can go back to the table that you probably hated when you saw it from your doctor. And this is the table. Absolute cinema, isn't it? Now I explained literally everything on this table. So now you can go to any etiology and understand how it happens, but it's just in a table. Then there is another table. Now, you know, this one, the chart. But before we go to that one, let's go back to our beautiful drawing. Let's go back to our first dear friend, and that is the, let's say, okay. The next slide will be explained by what I'm gonna say now. So, you know how we talked about water volume in the plasma, by the way, this is in the plasma, and sodium in the plasma. But what about the urine? What's happening in the urine? And as nephrologists, urine is important to study. So what's happening in the urine? Here's the importance. So we need to understand the urine osmolarity. So basically concentration, is it dilute or concentrate? And the amount. So what makes up the urine? Let's put 3 components and then play a game. So we have sodium, our main character. We have other solutes. So those are other solutes that play a role in concentrating the urine. And we have water. Water dilutes the urine. Let's take it step by step. I will tell you a disease and we will play the game together. In the situation of CHF, liver cirrhosis, nephrotic syndrome, or even bleeding, what do all of these have in common? I will highlight it for you to give you a hint. Look at this, look at this, look at this. What do all of these have in common? They have increased ADH and increased aldosterone. So let's go back to the urine. Let's go back to the urine. You can see it on the screen. So let's say in those situations I just mentioned, sodium in the urine will be increased or decreased. You tell me if I have aldosterone right now in any disease that causes aldosterone and ADH, sodium in the urine will be increased or decreased. Think about it. Yes. So we said sodium increases the absorption of water. Sorry, aldosterone increases the absorption of water and sodium. Sodium and then water follows. So because of aldosterone, there is decreased sodium. What about water in the urine? What about water in the urine? I'm talking in the urine. Decreased. Very good, because we are reabsorbing it. Isn't that true? We are reabsorbing it. Other solutes, it's just, you know, potassium, urea, whatever. We don't care. So is this urine concentrated or dilute? Think about it. Because we have other solutes with less water. So this is actually concentrated or hyper osmolar or hypertonic. Okay. This is in the presence of aldosterone ADH. So now you understand when there is ADH, aldosterone, there is hyperosmolar urine and low urine flow and low sodium. So let's go back to the table. Look at this. High urine osmolarity. High urine osmolarity. We studied this one just now. Low perfusion. So basically there is low blood going to the kidney. So the kidney think that we need more water. So they release aldosterone and the brain releases ADH. And this way you have more sodium retention, more water retention, water dilutes, and then you have nothing to excrete except other solutes. That will be high urine osmolarity, low urine sodium. You agree it's low urine sodium. Let's go back to another example. Symptom of inappropriate ADH. Ladies and gentlemen, let's play the same game. Sodium. Okay. Other. H2O. So, I mean, it's pretty obvious what I'm highlighting and what did I put X on. Yalla, quickly. Sodium. Increase, decrease in the urine. In the urine. I will write it here so I don't get tricked. In the urine. Yes, increased. So increased sodium in the urine. Very good. Other. We don't care about other. H2O. H2O, ladies and gentlemen. H2O, ladies and gentlemen. Decreased. Very good. Very good. Very good. So now this urine is concentrated or dilute? Dilute, but there is this, there is that, and this is decreased. Why do you say dilute? Who's diluting it? Think. If there is low water, high sodium, normal other solutes. Yes, because water is the only diluting agent here. It's the only solvent. So if water is not there and it's being reabsorbed because of ADH, what's happening here? This is concentrated urine. Concentrated urine. And the sodium is high. The sodium is high. So this urine, a patient will come in, you will take a sample, test, ooh, concentration, ooh, so much sodium. This guy has ADH. Let's go back to the table. ADH dependent. Those on the left are ADH dependent because ADH is doing something. ADH dependent, by the way, means that ADH is present, and independent means ADH is suppressed. So in these situations, low perfusion, cirrhosis, liver failure, heart failure, you have bleeding or nephrotic syndrome. ADH is high, aldosterone is high. They are reabsorbing sodium and they are reabsorbing water. This concentrates the urine and this decreases the sodium content. In symptom of inappropriate ADH, because ADH is alone working, so you are taking water, leaving sodium out. So again, if you're taking water out to your body and the guy is peeing basically the solutes and the sodium with little amount of water, this is a concentrated urine or high urine osmolality with a high urine sodium because aldosterone is suppressed. Suppressed why? Because of inappropriate ADH. Done. What about the other? The other is honestly very easy. If you look to the other side, it's basically, let's look at, for example, polydipsia or polyuria. If someone is drinking so much water, he is diluting his blood vessels, but not us, like people who without disease won't drink so much water. So this applies to, say, someone with psychotic disease. There is a psychotic disease that keeps someone thinking he's thirsty. So he'll keep drinking like exceptional amount of water. He will dilute his blood vessels. Sodium will go down, so hyponatremia, which is here. And what do you think about his urine? Because he's drinking so much water. You see how when you drink sometimes so much water, you go to the bathroom, akramakum Allah, and your urine is lighter in color. That's because it's dilute. So here it's dilute, not concentrated. This one is opposite. Low urine osmolality because he's drinking so much water and high urine output, if you notice, right? The other example that I want to give you, which is renal failure, we said the kidneys have a job. That job is to give back water, so reabsorb water, reabsorb sodium. If it does not reabsorb water or reabsorb sodium, it will flush out the water and the sodium. And it will be dilute because water is basically more now than sodium. And if you notice, it will be high urine sodium in renal failure. So that's how you want to think. Think about the etiology or underlying disease, and then think what this disease will do. So if the kidneys are failing, what will happen? Kidneys, they normally reabsorb water and sodium. If it is failing, then the urine will have so much water and it will have more sodium than usual. And because it has so much water, it's probably dilute. Let's see. Yes, it is. Simple. Simple or not simple? Simple, صح? You can tell now how urine osmolality is high or low. And by the way, in all the right side, ADH is not working. Why? Because it wouldn't make sense if someone is drinking so much water and is excreting so much water. Sorry, no, excreting it would, but if someone is drinking so much water to get ADH, like what ADH? I already have so much water. Why would you want to absorb more water? It should be the opposite. So in those scenarios, ADH is not working. ADH is working here though. ADH is causing the problems here. So that's why they call ADH dependent, because the problem is ADH. Here the problem is habits, and here the problem is kidney, not ADH. ADH here is innocent. Innocent. Okay, this is what your doctor covered. Now, for the clinical part, which if there is high NA in urine in renal failure, then how is it low urine osmolarity? Because, my friend, this much urine is not enough to make it concentrated. It's still dilute, because you need other solutes to concentrate the urine or the water. Sodium alone is not enough, right? You need urea. You need other stuff, but the kidneys are failing in excreting other stuff, because the kidneys, they secrete solutes and they reabsorb sodium and water. But if they don't secrete solutes and they don't reabsorb sodium and water are being flushed out, and the other solutes are staying inside. That's why they have hyperkalemia, metabolic acidosis, because they are not kicking out potassium, kicking out hydrogen, kicking out urea, and all of these are the ones that concentrate the urine. That's why the urine is not concentrated, because the kidneys are failing to excrete stuff normally. You're welcome. So this is it for the etiology. We are done to understand why. And the good news, by the way, is sodium or hyponatremia is the hardest part in this whole lecture. The rest is very easy. So clinical features, there isn't much that you need to really know. Just know the acute, chronic, mild, moderate, severe. So what do you treat? You treat any acute sodium hyponatremia, and you treat the symptomatic. So if someone has symptoms or it's acute, you treat it. How do you treat? One important thing you need to know that is a high yield in step one, and maybe someone will ask you about it. Do not rapidly treat sodium hyponatremia. Why? Because it can cause locked in syndrome. Yes, you're locked in. So, I mean, locked in mentally, not locked in with a disease. That's good. But if you correct it quickly, that patient might get the locked in syndrome, the disease, which is not good. So this is the important thing you need to know here. Honestly, like, if there is no sodium, just replace it. So this doesn't even need explanation. Do not drink so much water if someone has so much water already. So it's pretty much self-explanatory. There is not much for me to explain. Now we finished hyponatremia, which is, per lecture, it's the hardest part, but I find it very interesting. And once you understand how it works, you will feel so good. And just as I feel good about it, I'm sure you feel the same way. Now, hypernatremia. So hypernatremia is very straightforward. Look at this, and you might laugh at this. Definition: too much sodium. Pathophysiology: you either lose water or you increase sodium. Diagnosis: someone with dryness because he has too much sodium and less water. Treatment: just give him water, man. We are done with hypernatremia, guys. This was hypernatremia, bro. This is so easy, man. Look at this. So I'll add one slide. This is your doctor's slide. And here I might explain few of the etiologies. So let's say intake. So if someone just grabs, a salt jar and he just chugs it all, don't do this. This might kill someone. I'm not sure if it might kill someone. We need to find out. Don't find out. Don't find out. It's recorded. Do not find out. Do not do it at home. It's very bad. Or IV fluid, but I don't know why he put IVF. IVF is, in vitro fertilization, but that's okay. IV fluid, imagine if someone gives IV fluid more than the person can handle, that would be hypernatremia. Exercise, if someone, like the marathon runners, they can lose water and they can get hypernatremia. What else? Uncontrolled diabetes, as we said earlier, diabetes can cause hypernatremia by taking out the water to the kidney, because the glucose is osmotic. So the osmotic gradient can drive water out from the vessel to the kidney, and this can cause concentration of sodium. Wow, my light just went out of charge. I need to charge it. 1 second. 1 second. Okay. We are back. So, as we said, mannitol. So imagine someone takes mannitol. Mannitol is osmotic, so it will drag the water in the intestines, and this will concentrate the blood or the plasma, and it will cause hypernatremia. Diabetes insipidus, which is the opposite of symptom of inappropriate ADH. In this one, ADH is not working. So imagine if the water is not being reabsorbed because ADH is not working, so the water is being flushed out. Then what happens to the blood or the plasma concentration? Hyperosmolar. So what happens to the sodium concentration? Increase. So that's hypernatremia, right? So this is really easy, by the way. I'm just going through it to make sure you understand the concept, not just memorize the table. But yeah, this is pretty enough. This is very nice. I love this slide, honestly. It tells you everything. It's better than hyponatremia, right? The hyponatremia is too much. This one is straightforward. Potassium, also known as the banana ion. A lot of people talk about, oh, take your potassium, eat banana, and dates, by the way. Dates, bananas, they have good amount of potassium. Anyway, I'm not a nutritionist, but I'm going to talk to you about potassium. Let's talk about potassium. So potassium is actually rich intracellular. So in the cells, there is more potassium than out of the cells. Out of the cells means in the blood, which is why in the blood there is like 5 MEQL potassium, and in the cells there is like 100 or some or so. So in the blood it's like little. We know this. And in the kidneys, potassium is actively secreted and then reabsorbed. So if the kidneys are failing, you can't actively secrete potassium, so potassium will stay, and you can imagine this is an etiology for hyperkalemia, correct? But we'll come to it. Na or sodium potassium ATPase pump is a VIP today, and we will see why. It's very important. Hyperkalemia, same structure. We'll define it. We'll say what causes it, what features you can see, how to treat it. And this reminded me of a reel. If you saw the guy, like some famous, I think Nasser al-Qasab or something like that, he was doing a skit about how the consultant or the chief resident in the morning rounds in IM will wake up as like, good morning, how do you treat hyperkalemia? Or in Arabic, he says it. So if you're familiar with that, you will be able to answer it, inshallah, and you will not fall in the same trap that the guy fell into. So you will understand how it's treated. And it's very interesting, by the way, how it's treated. Watch this. Definition, easy. More than 5.2. That's hyperkalemia. That's normal range. More is hyper, less is hypo. Next. Oh, etiology. So etiology means how it happens. So there are 3 causes. Either there is potassium excess or extracellular shift, because we said potassium is intracellular. So if it goes out, that's extracellular shift, hyperkalemia, or extracellular release. Similar concept. Watch this. This is very pretty. So potassium excess, let's say this is potassium, or this is your input and this is your output. So your mouth and then your kidneys. If someone eats more potassium, basically, or takes potassium supplements, or takes medications that have potassium, or takes IV potassium more than the needed, that's hyperkalemia. Straightforward. No playing around. If someone, for some reason, has a disease or takes a medication that inhibits potassium release or secretion, decrease output, like we said, kidney failure. So the kidneys, they should actively secrete potassium. So if they can't, or they're failing at their job, potassium will stay, hyperkalemia. Let me tell you about the other 3. Now we need to draw. It's drawing time. Let's draw. We'll go a bit to the right. And we will draw. This is the lumen. You can see the lumen. This is the kidney, okay? It's a tubule. So this is tubule, this is the lumen. I'll just put a little space here just for the sake of visual. So in the lumen, you have potassium, okay? And you have something called the sodium potassium ATPase pump, Na/K, whatever, you know it. You know it. So the Na/K or the sodium potassium pump, what does it do? What's the function? It reabsorbs sodium. Let me do a different color actually. Reabsorbs sodium and secretes potassium. That's how it secretes potassium actively. Because it's an ATPase, you need ATP to use it. So that's why the potassium is active secretion. So we have our best friend. Remember our best friend aldosterone? Aldosterone activates this. So remember how we said aldosterone increases sodium reabsorption? That's how. That's how it increases sodium reabsorption by activating the NAK pump. What else? Let's go back and see what. So in CKD, this is not working. In kidney failure, it is not working. K-sparing diuretics, K-sparing, basically inhibit aldosterone receptors. So they inhibit aldosterone receptor. The other one, the last one, is hypoaldosteronism. So basically, you have no aldosterone. So you also are not activating. That's how you have a hyperkalemia. The last one is ACE inhibitor. ACE inhibitor basically opposes the RAS system, and the RAS activates aldosterone. So this will also inhibit aldosterone. It's the minus. So now you understand how hyperkalemia can happen from increased input or decreased output. Basically, it all comes back to this MVP. This is the main character of today. This is one way, potassium excess. The other way, extracellular shift. Extracellular shift. So potassium was inside and then went outside. How and why? Let's check this out. I will zoom in into the intracellular space and extracellular space. This is a nice animation. I hope this animation will explain exactly how things work. Again, just as we have in the tubules, NAK pump or sodium potassium ATPase pump, we also have it between cells and blood vessels. Again, what does it do? It takes potassium against its concentration in gradient and puts it in the cell. And it takes sodium against its concentration in gradient and puts it out of the cell. That's why it's an ATPase. It needs ATP. And this one, you took it in first year, the direction of sodium potassium. This is the active. You remember active transport? This is it. This is from first year. So, simple. How, looking at it, how can I cause hyperkalemia? What will happen if I just suddenly stop this? Hyperkalemia or no? Hyperkalemia, right? Because now we can't put this potassium inside. It will stay outside, and potassium outside means extracellular shift. Hyper. So just inhibit it. That's extracellular shift. Extracellular shift. So now the potassium will stay outside in the extracellular space. And caused by what? Beta blockers, digoxin. Those are examples that can inhibit this channel. Another etiology that your doctor mentioned is acidosis. Okay? Wait, let me not spoil. Let's go back one step. You see how the sodium hydrogen pumps sodium out and hydrogen in. So let's take it a step further. If we have too much hydrogen or acidosis, this hydrogen has to go somewhere. So it will go inside in exchange of sodium. So sodium went out, hydrogen went in. But now, because there's so much acid, this is caused by acidosis, the sodium inside the cell is depleted. Now, if the sodium inside the cell is depleted, what will happen to the sodium potassium pump? And what did we say about stopping the sodium potassium pump? If we stop it, that's hyperkalemia. So now we understand beta blockers, digoxin, metabolic acidosis, or any acidosis for the matter, causes hyperkalemia. So hyperkalemia and acidosis, they usually come together. حلوين. It means good. Yes, good. Very good. This is regarding the etiology of extracellular shift. Very well. Finally, and it's the easiest one, it's basically extracellular release. So as we said, the cells, they have more potassium than the blood. So imagine this cell dies, that's it. If the cell dies and breaks, it opens, the potassium will go outside. That's it. What can cause the cell to die? Tumor lysis syndrome. So lysis, we're killing the cells. Hemolysis, so hemolysis, you're killing the RBC, potassium escapes. Rhabdomyolysis, so again, lysis, you're killing the muscle cells, potassium escapes. That's it. Hyperkalemia. Done. Wow, that was nice. We're done with hyperkalemia already. Clinical features, two main ones are muscle weakness, because remember from first year, potassium is important for what? Repolarization, action potential, etc. So if you have hyperkalemia, you will interrupt the action potential in the muscles, and the heart is a muscle. You will also cause arrhythmia. And this is the severity of arrhythmias, how much potassium corresponding with how much change you will observe in the ECG. And the worst is sinusoidal ECG, which is ventricular fibrillation, and it could be deadly. So yeah, this is the manifestation of hyperkalemia. Treatment. Now remember what I told you about the video. This is a treatment. So from this, if we said beta blockers, cause hyperkalemia. So beta agonists reverse it. If we said acidosis cause hyperkalemia, so alkalosis reverse it, causes what? It reverses it. It fixes the problem. And you need to understand that insulin acts on the sodium potassium pump. So insulin also works. So here in the treatment notice, insulin with the glucose. Why did we give glucose with insulin? Well, the reason is very simple, because the guy has a problem with potassium. His glucose levels maybe are at 80, so it's normal. So if we give insulin to normal level of glucose, the glucose will go down. So we'll give glucose again, right? So we'll give glucose again. So we give insulin to correct potassium, to bring it from hyperkalemia to normal, and the glucose, we don't want it to fall down because of the insulin we're giving, so we give D50 or glucose. Beta agonist, as I told you, this is inhaled albuterol. It reverses hyperkalemia because beta blocker close, this one opens. Sodium bicarbonate. So if you have acidosis, you give an alkaline. Bicarbonate is the base. So you reverse acidosis because of hyperkalemia, and you also fix it. Calcium gluconate. So this is for the heart. It's a bit advanced, but because you don't want the heart to cause. Yes, someone said calcium gluconate. Yes, correct. Because the heart arrhythmia. So you don't want to cause the arrhythmia, so you give calcium gluconate. And you also check ECG or EKG, repeat labs to check the potassium levels. You can give potassium binders, which is basically it sticks to potassium and gets excreted. Furosemide is a diuretic. It flushes the potassium out through the kidney. Dialysis is basically you're literally cleaning the blood out from the potassium. So you take the blood from the blood vessels, you clean it in a machine, you give it back clean. And this is you give it where? Chronic kidney disease. If the kidneys are failing and they can't secrete potassium, so you give them dialysis, it will clean it from potassium itself and fix the problem. So now, this is the video I was referring to. If someone asks you, what is the treatment for hyperkalemia? You are very smart, you know the treatment for hyperkalemia. This is important, by the way. Even for steps, it's important. So, yeah, that's it for hyperkalemia. Now, hypokalemia, same system. The banana won't be there for long, I promise. It's gone. This is hypokalemia, opposite, low level of potassium. And it's also very easy. Look at this. Etiology, basically reduce intake. So if someone in deprived area, they have no food, and I pray Allah to help anyone with no food, and they can't find anything to eat. May Allah bless them and help them and protect us. So reduced intake, malnutrition cause hypokalemia. Increased output, as you guessed, probably, if you give more diuretics, or you clean the blood more than you should, so more dialysis than you should, or urinary loss. So I will tell you something now. You see extracellular shift in hyperkalemia, intracellular shift, so the opposite in hypokalemia. So acidosis causes hyper, alkalosis causes hypo. You give insulin to treat hyper. If you give too much insulin, you cause hypo. You beta blocker cause hyper, beta agonist cause hypo. So just take this one and reverse for hypo. If you activate it, it's hypo, okay? So reverse, literally. You see the treatment for hyper, all of these cause hypokalemia. So it's like you reverse it. So now go to, this is alkalosis. So here I'm explaining to you how alkalosis causes hypokalemia. So notice there is no hydrogen ions outside, right? And now what will you expect the pump to do? It wants to stabilize the level of hydrogen, so it can't. It will stop. Why did it stop? Because there's not enough hydrogen to take inside. What will happen to sodium levels in the cell? Look at the sodium level. Increase. Because the sodium hydrogen pump cannot exchange hydrogen for sodium. So the hydrogen outside is not enough because it's alkalosis. And inside the cell, what will happen? More sodium build up. Now this sodium needs to escape. Where will it go? Through which pump? You already guessed it. This pump. Now this pump will exchange sodium for potassium. What happened outside? Hypokalemia. So it's the opposite of acidosis. You see how acidosis exchange and then influences or stops the sodium potassium pump. This one activates the sodium potassium pump to correct the sodium and hydrogen levels, basically. And these are the clinical features. Again, potassium is important for contraction, for action potential, and the heart arrhythmia. So as you imagine, if you don't have it, you can cause what? Arrhythmia, irregular pulse, syncope. The intestines have muscles, so constipation. The bladder have muscles, so cause polyuria, neuromuscular cramps, and these are the ECG manifestation. Treatment, literally very straightforward. Just give him potassium. And there's a note by your doctor. He said, make sure the magnesium is corrected. And it's true. This is, this you'll never forget it because it's a warning from AMBUS, actually. It says potassium supplementation will be ineffective if concurrent or occurring with hypomagnesia is left untreated. So you need to make sure that you treat both. Make sure that the magnesium is treated because if magnesium is not there, basically, the potassium will just escape. So magnesium needs to be there to hold it in and be able to reabsorb it or keep it in the blood. Finally, in this lecture, your doctor wanted you to know one thing that I will explain here really quick, which is the aldosterone triad. Remember what we said about aldosterone? It activates an NAK pump. Let's go back. It actually also activates another pump. Aldosterone. There is another pump. And that pump is the NaH pump, sodium hydrogen pump, right? This one. So it activates it. So aldosterone activates this one. So what will happen when this one is activated? But hydrogen will leave and sodium will enter. Because remember, aldosterone is pro-sodium. It wants sodium at any cost. It will sacrifice potassium. It will sacrifice hydrogen, all for sodium. So let's go back to the aldosterone triad. So aldosterone will activate the NAK pump in the tubule and lumen. This is in the kidney, by the way. Read tubule, lumen. This is in the kidney. So it wants to get back sodium. So sodium reabsorption increase. As a result of sodium reabsorption, remember water follows sodium. So H2O reabsorption increase. And because we increase the sodium and water, what will happen to the blood pressure? Increase. Hypertension. At the same time, we are sacrificing potassium and we are sacrificing hydrogen in return for getting more sodium in. What will happen? Decrease potassium absorption, so hypokalemia, and decrease hydrogen absorption, so alkalosis. And this is the triad of aldosterone. When do you see this? When there is excess aldosterone, like in Conn's disease. You know Conn's disease, when there is excess aldosterone, when there's a tumor or a mass, and then you will find a manifestation of too much aldosterone, like high blood pressure, and then you test the urine has so much potassium, so much hydrogen, and his blood has low hydrogen. sorry, low potassium and high pH, right? What's happening? Aldosterone triad, remember. And this is from UWorld, our best friend. We all love UWorld so much. This is a table from it. Don't worry about aldosterone escape, but if you are wondering, this just means that the kidneys are smart. They can limit edema by excreting water through other mechanisms like high pressure causes water excretion. So it compensates for the edema, but unfortunately still causes hypertension. Oh, we're already at questions, but this is for lecture 1. So don't leave yet. This is for lecture 1. Lecture 2 is acid base, and acid base is no easier, bro. It's very easy. It's very easy. I mean, it's much easier, not no easier. This is no easier. Yeah, acid base is very easy. You will see. So let's solve some questions, refresh our mind, and then go back to the second lecture and finish it, inshallah. So this is also from UWorld. So these questions, just a disclaimer, these questions are pretty difficult at your level. So at your level, they're kind of tough, but I know you can do it, and you got it. I will read. A 44-year-old man comes to the hospital due to acute onset of central chest pain radiating to the left arm. He used cocaine a few hours ago. That's not good. Blood pressure is 160 over 100. Pulse is 98 beats per minute. And respirations are 18 per minute. On examination, the patient appears anxious and diaphoretic, so diaphoresis, he's sweating. EKG shows ST segment elevation in the anterior lead. ST elevation. Lab reveals what? What the lab reveals? Elevated cardiac troponin and serum potassium concentration of 3.1. Which of the following is most likely the cause of this patient's hypokalemia? Now, at first you'll be like, oh man, I don't know. But no, you know. You know. So he has what? High blood pressure, low potassium. What can you deduce from this? Where is potassium going? What hormone can cause high blood pressure and low potassium? Aldosterone. So which one is the answer, you think? But it's actually not the aldosterone doing this. Because he took cocaine. So do you think it's what, A, B, C? What do you think? See, it's a bit advanced. I was a little bit skeptical about putting these questions. No, it's not B. And yes, it's C. Increase intracellular shift of potassium. So remember the hypokalemia, how it happens? It's the opposite. It's okay. It's okay. Don't worry about it. But there is no potassium and sodium exchange in the intestine. This is, I don't think this is even a thing, especially given his situation. So, guys, cocaine is what? Beta, adrenergic, or antagonist? It's beta, adrenergic. It's a bit, I know it's a bit skeptical. It's kind of, you need to be, oh, this is cocaine. So cocaine is beta adrenergic, and this will do what to the NAK pump, sodium potassium pump. Remember the beta adrenergic? What will it do to the sodium potassium pump? Get this one out and you redeem yourself. It's okay. Get this one right. What will the beta adrenergic do to the sodium potassium pump? Activate or inhibit? Let's go back to review it. Uh, where is it? Go all the way. So if beta blockers stop it, then beta adrenergic activate it. So this will cause what? Hypokalemia. So remember, beta blocker blocks it. Beta agonist activates it. So it will shift potassium inside. So cocaine activates NAK pump, and this will pump the potassium inside the cell, and this will cause what we call intracellular shift. See, it's a bit too much, by the way. Your questions in the exam will be nothing like this. Nothing. Bro, your question in the exam might be a joke after you study this. And I'm telling you this because I've been through the exam. The doctor is very nice that he knows this lecture is relatively quite challenging, right? I don't know why they think this. So he won't get such questions. These questions are a bit advanced for your renal, but they're nice to think and test your ability to apply what I just taught you. So it's just, this isn't what your renal exam will look like at all, like impossible. Okay, next. See, it's a bit, I will go quick. I will try to go quickly and help you with this because it's the same thing. So this one has something you know. Okay, this one has something you know. So this patient, okay, she got high blood pressure and she's stressed. So she's getting stress. So it's a stress hormone. And high blood pressure, who causes high blood pressure? Cardiac examination, find full pus, no edema, and it shows low plasma renin activity. Ooh. So this means, and it also shows you that there is a mass in the adrenal. What hormone comes out of the adrenal? Hint, it's not, I don't mean pheochromocytoma. This is not pheochromocytoma. There is another one that had a triad, right? It comes out of the adrenal. We kind of call it Cohn's disease, maybe Cohn's disease, right? Aldosterone, yes. So we said adrenal mass. And why do we know it's aldosterone? Because renin is low. So aldosterone, negative feedback on renin will go down, and there's high blood pressure. So continue the triad, complete the triad. Who does aldosterone love? Okay, you know what? What's a triad? First, what's a triad? High, low, صح? Yes, it loves sodium. So sodium, leave it aside. So bicarbonate, high or low? What's a triad? Say it. What's a triad? Hypertension, you already have one. Two is alkalosis. Three is hypokalemia. So alkalosis, which one is alkalosis here? See, easy. Which one is alkalosis? A and B, right? A and B. And out of A and B, which one is hypokalemia? Okay, both. So both are alkalosis, both are hypokalemia. And you said aldosterone loves sodium. So which one between A and B would you choose? Yeah, B. Simple, right? Simple. Yes, B. Correct, true. It's B. This is it for the electrolyte lecture. Do you want break or should we just move on and kill this lecture too? Because this lecture is much easier than the one before it. Acid base. I can assure you that. But I can also assure you it's kind of subjective. So for me, it's easier. Okay. Bismillah. So I taught the acid-base lecture. If you were with me during pre-med, then you know I taught it, and then I taught it to another batch. I think the batch 1 year younger than you. So let's go back and recap some basic concepts about acid and base. Once upon a time. So this is a recap from my old lecture. If you remember these drawings, my cheap drawings. So acid and base, basically acid, anything that gives hydrogen ion. And so anything base is that accepts hydrogen ion. So this one gives hydrogen ion. This is acid. Which one is more acidic? The one with more hydrogen. So hydrogen ions make solution acidic. This is just recap, by the way. This you should know from first year or even high school, but it's okay. Recap. We're still recapping. So once, if you see this is a recap, once upon a time. So we understand how to measure pH. pH is basically the concentration of hydrogen. So in bottle one, we have this much. So we have 5 zeros, and here we have 6 zeros, and here we have 8 zeros. So when we have more zeros after the decimal, before the whole number, this is actually a less number. So the concentration is less. So which one is more acidic out of these three? It's bottle one. So if we do the conversion, negative log, and then the concentration, this will be pH 5, more acidic than pH 6, more acidic than pH 8. This is also recap. So we're just saying that the concentration is written that way, and then this one is translated to the pH or the logarithmic function of the concentration of hydrogen. So this basically means the concentration of hydrogen. The less the number, the more acidic, because imagine little number to the power of, so 10 to the power of a small negative number. And if the negative number is smaller, this means that the whole number is bigger. So I'm just telling you this, by the way, it's just, I'm yapping about you know, how do you calculate hydrogen and how do you understand pH. But this is just basic. It's just basic. So this is the negative logarithmic function of hydrogen. Higher concentration of H means lower pH, and this is Another example, so this is more concentration, this is less concentration, so this is more hydrogen, and then this would be pH 3 versus pH 7. You see how it works? That's the recap. I'm also still recapping. So we can also recap that this is the bicarbonate buffer system. Why I'm showing you this? Because I'm showing you that the CO2 is acidic. How? Because it yields hydrogen and bicarbonate. You will say, oh, but hydrogen and bicarbonate cancel each other out. Not really, because hydrogen has more influence than bicarbonate. So one hydrogen will make things way more acidic than one bicarbonate would make things basic. Uh, so that would make carbon dioxide acidic. Why we agree on this? Because we will apply this when we talk about respiratory acidosis, basically keeping CO2. So how do we maintain pH in our bodies? I'm kind of speed running because these are not the things you need to know for this lecture. By the way, this lecture we had 0 questions from, just to let you know, 0 questions from. And if you're gonna have a question, you're gonna have a very silly question from it. So we're gonna kind of over study or over explain just so you understand and become an exceptional, have exceptional understanding, become a very nice expert in this topic. But for your renal exam, you don't need this much more. The renal exam will be very easy regarding pH, inshallah. I don't know if anything changed since my year, but in my year, we had 0 questions and everyone talked about it. We're like, oh, wow, we all freaked out for this and we had 0 questions. But after this, you should hope that you get questions because now it's going to be free questions for you. You can't miss it. You can't miss it. How do you maintain pH? Proximal tubule, basically in your kidney, it absorbs bicarbonate. Distal tubule, it secretes hydrogen. So this is maintaining pH, right? We're excreting the acid, taking back the base to keep things cool. Buffers, there are some buffers in our system. There are many buffers. There are protein buffers, bicarbonate buffer. One buffer that your doctor talked about is ammonogenesis. Basically, you see this NH3 has 3 hydrogen. It accepts one and leaves. So it's like, I take one with me and go. So that's what happens in ammonogenesis. The doctor said, don't overthink it. So I'm not going to overthink it either. Just let it there. And this is how it happens. See, NH, it will accept one hydrogen and become NH4 and leave the tubule, get excreted. Bye bye. That's how it carries the hydrogen. So all of these are making things more basic. And for the lungs, if you have too much carbon dioxide, so remember this equation, it takes the hydrogen, makes it carbon dioxide, and your lungs also contribute to pH by excreting the carbon dioxide out. That's how we maintain pH. Until now, we haven't touched upon anything crazy. All of this is just ground rules. Again, recap, what can go wrong? Many things, actually. If the change is in carbon dioxide, so there is a change in the carbon dioxide, it's a respiratory cause, and you agree with me. This is since first year. And if there is a change in the concentration of bicarbonate, this is a metabolic cause. Because look, this is kidney and this is lungs. So one is metabolic, which is the kidneys, one is respiratory, which is the lungs. Acidosis, alkalosis could be either with either. This is a chart I put just for your reference if you want to test yourself and see how pH changes with, for example, carbon dioxide. So when carbon dioxide goes up, this means more acid, this means less pH. When carbon dioxide goes down, this means less acid or higher pH number. Bicarbonate, if it goes down, it means this is less base, so more acid, less pH. If it goes up, this means more base, so higher number of pH or less acid. Is this all clear to you? So far, did we say anything new or anything unexpected? Clear, very, very good. This is very good. This is the whole lecture. This is the whole lecture, guys. If you know this, if you master this slide, which is just 3 words, you will master the whole lecture. Let's start drawing and giving you examples. Maybe I can take this and keep it for your reference. I'm just keeping this for your reference, okay? Where did this go? Oh my God. Why did this go so far away? Anyway, it's okay. This is the reference of normal range. So now we will draw next to it. So we have the golden values, pH. the pH. You have the pressure of carbon dioxide, or basically how much carbon dioxide you have, and you have bicarbonate. Sorry, it's CO3 minus. Let's play a game, guys. Let's play a game. Stay with me. Now, if the pH, you see the normal range, so you should know this, 7.6. These numbers are hypothetical, okay? They are not accurate. I'm just making up numbers for the sake of explaining the concept to you. So understand the concept first, then we will talk about the numbers. If the pH is 7.6, is this acidosis or alkalosis? Think and tell me. Okay, alkalosis, alkalosis. Okay, yeah, it is alkalosis because this means less hydrogen. So alkalosis. Now, here's the game. Let's say the carbon dioxide is 20. Is this number, does it cause acidosis or alkalosis? Why? Why 20 carbon dioxide means alkalosis? Less CO2. What's so special about CO2, doctor? Why is less CO2 means alkalosis? Yes, because CO2 is acidic, so less of it means alkalosis. MashaAllah. Alkalosis. So far, this is still not the third year level, but it's good that you know it because this is what you will be doing for your step one, by the way. This is how you will think about questions. Oh, pH is this, CO2 is that. If we say this is 15, is this acidosis or alkalosis? Like this alone. Acidosis, okay, okay. Why? Because we have less base. So if a patient comes in with this, with these numbers, how can you clinically describe what's happening? What do you say? Oh, salam alaikum, doctor. He has, what does he have? Wow, mashallah, you got it immediately. Respiratory or or just like this. Alkalosis. What about, I mean, your answer is half true. With what? Compensated. Say it full, man. Say it full. Respiratory alkalosis compensated by metabolic acidosis. Yeah, so yeah, compensated by metabolic acidosis. Now, this compensation part is not accurate, as I said, because there is a table of equations. I'm sure you saw it, and no, it's okay. Don't be sorry. I'm sure you saw it, and you were shocked about this table. Our time, we did not get a single question with an equation, but this equation, I will show it to you. These equations basically tell you how a human is supposed to respond to a change in a number. So let's take metabolic acidosis, for example. This equation just tells you if a normal human got an amount of bicarbonate, then his lungs should react this way. And it gives you the number of carbon dioxide that he should have in a normal human. Okay? This is what it says. But I don't want to spend so much time there. I want to go back to this example. I want to spend more time here. This is what matters to me. Because I want to make sure you understand what's happening. Okay, let's keep playing the game. Because if you understand this, by the way, you're done. The lecture, خلاص, this is it. If you understand this, you're done. pH is 7.2, my dear. And the carbon dioxide. Okay, first of all, pH. What's this? Okay, okay, okay. And if the PCO2 is 60, what's this? Okay, good, good, good. And if, let's say, this is 30. Oh, I'm not gonna write it. Yeah, you tell me. Okay, that's good. So don't tell me the full. I wrote alkalosis. Oh my God, Oh, forgot so many letters. Alkalosis. My bad. So alkalosis, yes. So how is pH acidosis? Is pH less or more than the normal range? You tell me. Is it more or less? No, 7.2. This is maybe my handwriting is not good. So this is 2. Wait, let me correct myself. I will write you a fancy 2. This is 2. 7.2. 7.2 is less than 7.35. So that's less. I think you confused the number, maybe? Yeah, you confused the number. No problem. So this is 7.2. So I don't want to tell you, I don't want you, no, it's okay. I don't want you to tell me the whole diagnosis. Just tell me who's causing the problem. Is it the lungs or the kidneys? Or is it respiratory or metabolic? And what is it? Respiratory, the lungs, yes. So this is causing the problem. So it's respiratory acidosis with metabolic alkalosis. Very good. Last scenario, and then we will move on the table and tell you what's the purpose of the table. Last scenario. Let's say the pH is 7 point. Again, 2. No problem. This is 2. And the PCO2 this time is also 60. Also 60. However, this is 10. What's this? Acidosis. Acidosis, right? And what's the last one? Who's causing the problem? Yeah, who's causing it? Hmm? Who's causing the acidosis? Both. Exactly. Yeah. Don't overthink it. You look at the pH and then you look at the lungs, what are they doing? And then you look at the kidneys, what are they doing? So yeah, both are doing not good, honestly. So it's a mixed respiratory and metabolic acidosis. So yeah, you don't need to overthink it. It's literally that simple. It's literally that simple. That's how you want to read it. That's how I want you to do in your exam, whether it's the renal or step 1. You look at the pH. Oh, sorry. You look at the pH and you assess. And then you see which one caused the pH. So which one agrees with the pH? This is the one causing the problem. And then you look at the other one. Maybe both are causing the problem. Maybe one is causing, one is good. So you check which one is causing the problem. Easy, صح? Easy, very, very easy. Now, this one is just telling you what a normal person or how a normal, for example, lung should react to a certain number of bicarbonate. Let's take the first one, for example, metabolic acidosis. Let's take it, for example, okay? Let's take it. I will write it here. So 40 minus 1.2 times 24 minus HCO3. Okay, so let's solve. Let's say this is for metabolic acidosis. So this is for MA, metabolic. Oh, there was acidosis, M not acid. So what this equation tells you is this. Let's say someone has 7.1. So acidosis, right? And he has, we said metabolic, so let's put this at, I don't know, 15. Metabolic acidosis, you agree? You agree this is metabolic acidosis, right? Before we look at the PCO2, let's change the color real quick. Before we look at the carbon dioxide, let's plug this into the equation and see how much, because this is basically PCO2 equal. This is the expected carbon dioxide concentration we can find in a normal person. So in a normal person, the carbon dioxide should be this number, should be 1.2 times, and then you have 24 minus 15. This is what we did. Calculator real quick. So we have, this one is 9, and then 1.2 times 9 is 10, this one is 40. That's about, so let's write PCO2 here. That's about 29.2. Okay? So what this equation tells you, my dear, is that, okay, yeah. So what this basically tells you is that in a normal human being, the carbon dioxide concentration in response to 15, in response to this, to compensate, he should have this much carbon dioxide. This is in a normal human being. In a healthy lung, the lungs should do this, compensate for level 15 bicarb. So now we check the patient. Let's say the patient has 33. Now 33 is lower than 35, right? So you would say, oh, this is alkalosis. Initially, you would say, oh, this is alkalosis, right? So it's compensating. No, this is non-compensatory because this is not enough. Enough would be 29. This is not enough, guys. Not enough. So this is uncompensated respiratory alkalosis. So he probably has two problems: metabolic acidosis and respiratory alkalosis. Okay. Scenario 2 is when a patient has 29 compensated. So this one is what? This one is metabolic acidosis with respiratory alkalosis compensation. Sorry, with the previous one, 33 is not alkalosis, so it's acidosis, by the way. I said this by mistake. At first, you will think it's alkalosis. I didn't tell you this. At first, you will think it's alkalosis, but in reality, it's acidosis. Why? Why is acidosis? Because it's more than the expected value. And what we said, if carbon dioxide is more than the normal value, so this is the new normal value. The new normal value is 29. If carbon dioxide is more than that, that's acidosis. So this guy has mixed acidosis. You might think it's alkalosis, but no, it's not. I didn't tell you this at first, so now I'm telling you this. However, if it's 29, that's good. That's compensated. So this is compensated. So this is, sorry, metabolic acidosis with compensated respiratory alkalosis. If it's, let's say, 15, for whatever reason. Where's the red, bro? I need the red. This. If it's 15, you will say, oh, this is alkalosis, but no, this is way too much. You are supposed to do this only. You are supposed to get it down to 29, not to 15. So this is, yes, it is alkalosis. But it's what? It's another disease. So he has two diseases now: metabolic acidosis with respiratory alkalosis, both diseases, no compensation. So his pH here might actually look normal. It might look like 3.3, sorry, 7.3. It might look normal, but he has two diseases ongoing together. Did you guys understand what the equations are used for? They're just used for to see what do I expect the other organ. So if I'm looking, yes, I will explain it again. No worries. I'll explain again. I'll explain again. So say a patient, he has 7.1 pH. This is acidic pH. So he has acidosis. Or actually, you know what? We don't know what he has. We can't judge too early. His bicarbonate says 15. So 15 is acidosis. So we are sure that he has metabolic acidosis because of his bicarbonate. Do you agree? The pH is also 7.1, so it agrees with me. Now, the equation we use, this one just tells me what I should expect. So if I'm going to a clinic, I'm like, Assalamu alaikum, doctor. You said this guy has 15 bicarb. Okay, so let me put this in the equation. 29. Okay, so doctor, if his partial pressure of carbon dioxide is 29, then he's healthy, he's doing good. However, doctor, if it's more or less, we need to investigate further. This could be two problems at once occurring. You're like, okay, doctor, I'll go check. He will go check. Scenario number one. Scenario number one. In scenario number one, he will check the carbon dioxide. He will find it to be 33. Now, this guy will come back to me. Will be like, doctor, or to you. You know what? He'll come back to you. Like, doctor, his carbon dioxide is 33. And you said it should be how much? How much should it be? It should be 29, right? Because that's what you calculated because of his bicarbonate level. So based on his bicarbonate level, his lungs should put the effort to make the carbon dioxide 29. But his lungs are not putting in the effort. It's 33. So he'll be like, doctor, 33 is less than the normal range. I'll tell you, okay, wait. It's less than the normal range in a normal or healthy human. But in this human, he has less bicarb. So the lungs need to compensate. So if it's only 33, this means the lungs are not doing enough. They are not compensating enough. Is 33 more or less than 29? It's more than 29. And what did we say? If the carbon dioxide is more, this means this is acidosis. Now, because you studied this lecture, you will go tell this doctor, this guy, yes, he has 33 partial pressure, but remember, his bicarbonate is suffering. His lungs should work harder, but if they are not working hard enough, this means he has two problems, doctor. He has mixed acidosis. Another scenario, you will go and your colleague will tell you, doctor, I found that this guy has partial pressure of carbon dioxide of 25. Is he doing good? And his bicarb is 15. You will say, oh, okay, his bicarbonate is 15. Let me check the equation. Oh, based on the equation, his carbon dioxide or his lungs should be getting the pressure of carbon dioxide to 29. So if his lungs are overdoing it, then they are not healthy, my friend. So here, it's less or more than 29. It's less, right? So if it's less, it means it's alkalotic. So he's having two problems. This is not compensation. He is not compensating. He is overcompensating. And a healthy lungs should not overcompensate. They should compensate only as much as we want, as much as we need. So because they are overcompensating, this is actually alkalosis. So this patient has mixed, or let's call it metabolic acidosis with respiratory alkalosis. And his pH could be normal, by the way. Because of this, his pH could be normal, more or less, doesn't matter. But what matters to me is that this patient is not doing well. His lungs are not doing what they're supposed to do. They are supposed to do this, but they're not doing this. And if you change this number 15 to another number, the expected work of the lung will change. And that is all about these equations. These equations just tell you what do you expect in a healthy patient. And if the patient is not doing what he is supposed to do, then you need to investigate, is this number higher or lower? So is the patient doing worse as in alkalosis or is doing worse as in acidosis? And it applies to everything. If you expect someone to have bicarb of 20 because of an ongoing respiratory illness, and you expect him to have bicarb of 20 and his bicarb is more, then he is having also alkalosis. And if his bicarb is less, then he is having also acidosis. So don't be fooled by the normal values. Always check the equation to make sure that this patient is doing well in regards to his primary disease. Because those values, the normal values, you see those values are normal values in a normal patient with no primary disease. But in a patient with a disease of metabolic acidosis, alkalosis, or any of these diseases, you expect him to have a different value to compensate. And that's hence this whole thing. Now, regarding your exam, for step one, you don't need this. For step one, 100%, you will not need this. Never, never for step one. In renal, in our year, we never used it. In our exam, we did not use it. Okay, so you don't need it for maybe he gets a question. Honestly, I don't know if he changes his mind from year to year, but I hope not because memorizing them takes time. So just check with the doctor, maybe ask the BSc to check with him. But if you memorize it, it's easy to apply. It's very easy. The concept is easy. That's what you need to understand the concept, memorize it at home, no problem. Okay, final concept. Final concept is the anion gap. And I know this is also one of the confusing concepts, even though it's a very pretty simple concept. And I don't want you to overthink it. Inshallah, this last concept, and we'll finish the lecture. So anion gap normally consists of what? In your blood, there are sodium, bicarb, chloride, potassium, calcium, magnesium, albumin, some proteins, lipids. There are so many things in your bloodstream, but you only count sodium, bicarbonate, and chloride for anion gap measurement. You don't need we call them unmeasured anions. So you are not measuring other things. You are only measuring those things. And what's the equation? It's sodium minus the total of bicarbonate plus the chloride. This is just pure memorization. But what I'm trying to tell you here is that an ion gap that you measure is not the actual ion gap. It's just those four together, or those three, sorry. But I put four to make them equal, to two and two. So this is normal ion gap. This is non-anion gap metabolic acidosis. I know this is confusing now, but watch. It will become very simple. So what happened here? The bicarbonate ion was lost and the body replaced it with chloride. That's how you did not lose any anion. That's why it's normal anion gap, because look, they're the same, right? Two negative, two positive. Two negative, two positive. It did not change. Your body replaced it. So how does this happen? Why in non-anion gap metabolic acidosis the anion gap doesn't change? What makes it this way? So let me show you two etiologies. One is loss of bicarbonate. Two is inability to reabsorb bicarbonate. Watch. This is your lumen. It has chloride. It has bicarbonate. This is in a normal person. So a normal person will filter, and then they will go a little bit, and then he will reabsorb both chloride and bicarbonate. This is normal. Normal, good, healthy. He got both. See? No acidosis. No problem. Now the problem happens if he is unable to reabsorb bicarbonate for any reason, like in renal tubular acidosis. He cannot reabsorb bicarbonate. So what happens? Remember when you said bicarbonate is reabsorbed in the proximal tubule? Sometimes the proximal tubule has a problem, which is RTA, renal tubular acidosis, and the kidneys cannot absorb bicarbonate. So instead, because it's negative ion and chloride is negative, they compensate it by taking back one more chloride. That's why it becomes non-anion gap. Because the kidneys replace, and instead of, because they can't take bicarbonate, they take chloride instead. In another scenario, maybe you don't even have bicarbonate, like in GI loss, if someone has diarrhea or something, he lost the bicarbonate, so he did not filter enough, so he will reabsorb what? Also chloride. So in these two etiologies, basically, any etiology or any cause, underlying cause that causes loss of bicarbonate or inability to absorb bicarbonate, those cause non-anion gap metabolic acidosis. So you don't need to memorize the used part, the mnemonic, but just look at it. Diarrhea, you're losing. Chloride is replacing. So non-anion gap. Pancreatic fistula. So you're losing more chloride because bicarbonate is found in pancreas, so you're losing more. Acetosalamide inhibits the reabsorption of what? Of bicarbonate. Renal tubular acidosis, as I told you. The rest, same thing. Nothing to overthink. But I know what you are overthinking. You are probably wondering why in high anion gap metabolic acidosis does the kidney not replace the lost anion gap with chloride? Why? Did you ask yourself this question? I'm sure you did because you're smart. Let's see why. And what's the difference between HAGMA and NAGMA, or non-anion gap and high anion gap? So this is HAGMA, high anion gap metabolic acidosis. So basically what's happening here is that there is sodium, chloride, and the bicarbonate was used, not lost, was used, and it was replaced by an unmeasured anion. So for your kidneys will come look, we have 2 positive, 2 negative. We're good. No need to replace anything. However, here your kidneys will be like, oh, we lost. Let's replace. But here your kidneys will be like, we have this. Why do we need to replace? Huh? No need to replace. You have negative. However, in the lab, it will show that there is a gap. Now, in your body, there is no gap, but in the lab, it will show that there is a gap. And this gap is basically replaced by the unmeasured anion, or an anion that you are not measuring. So you're measuring only sodium chloride. Where is the other chloride? It's not being replaced because you don't need. You have this, but you're not measuring this. And because you're not measuring this, it shows you a high anion gap metabolic acidosis. Let's see how. This is normal. This is normal. And usually the etiology of high anion gap is basically an acid from outside. So salicylate poisoning, which is aspirin. Salicylic acid is aspirin. Lactic acid, ketoacidosis. So basically, whenever you add an acid from outside, this acid has what? It has hydrogen and an ion. This is HA is basically the hydrogen and an ion. It's a compound, acidic compound. This acidic compound will dissociate into H plus and an anion, random anion, whichever this anion is, could be from keto acids that are dissociated, like glutamate becomes glutamine, etc. We don't care. It's a negatively charged anion. And then the H will grab, or sorry, the bicarbonate actually will be like, I'm Superman, I'll go save the day. It will go and take this hydrogen and take it whatever, honestly, just, get rid of it. Or it will dissolve as water or whatever. So now, is there an ion gap here? No, right? 2 positive, 2 negative, nothing wrong. So your kidneys will not replace anything. They don't need to replace anything in this situation. That's why your body does not replace it. It just keeps it this way. This is good. This is fine. However, in the lab, which one do you count? You will be count 1, 2, 3. You do not count the unmeasured anion. You do not count any anion other than chloride and bicarbonate, which is why you will find in the lab test, oh, anion gap problem. So what etiology causes anion gap? Basically anything from outside. So anything acid, so glycol acid, oxoproline, lactate, ethanol, aspirin, which is salicylic acid, renal failure, because renal failure, it fails to excrete phosphorus acid, sulfuric acid, those stuff that are found in your kidneys, the buffers, it fails to excrete them, so the anions will stay. Ketoacidosis, because the keto acids. So anything that adds this thing, see this thing. So here you are not losing bicarbonate or not being able to reabsorb, because in NAGMA or non-anion gap, you are losing bicarbonate or you can't reabsorb it, so your body will replace it. But here, you are not losing anything, so your body will not replace anything because you already ingested or your body produced something that already has an anion. See? See? 1, 2, 3, 4. But you don't count this in the lab. So in the lab, it will show 3 and 1 is missing, anion gap. So in summary, high anion gap metabolic acidosis is adding an acid, and an unmeasured anion replaces bicarbonate. In anion gap metabolic acidosis, so NAGMA with the N, you're losing bicarb and the chloride ion replaces it. So when a measured, something you measure replaces something, you measure it. So it's no gap. But when something unmeasured, something you did not measure in the lab, so anything basically other than the 3 we mentioned, which is sodium chloride or bicarb, this is HAGMA. So you can see, now you don't need to memorize this. You just know that anything from outside that is basically an acid, it's HAGMA. And anything that is causing loss of bicarbonate or unable to reabsorb, that is NAGMA. Clear? I don't think anyone will explain to you HAGMA and NAGMA this way, because this is the ultimate way to understanding why we see an ion gap. in all of them, there is no real anion gap. The anion gap is only in the measurement, is only in the lab. But in the body, see, in the body, it's fine. But in the lab, that's where you will notice it. And it helps you identify what's the cause. If it's caused from something acidic or the cause is within the body, it can't, for example, synthesize bicarbonate or something. Very well. Now, we could solve one of them, honestly, but I think the doctor did a good job in solving them for you. I checked. The solutions are nice. We solved one. We solved a few ourselves when I gave the examples. So if you want me to go over a specific one, please let me know now. I can go through over one of them. But basically, what you do here, check the pH, and then identify what's causing it. So this is alkalotic. This could be causing, and this is causing. So here, two are causing it. See, because this is decrease and this is increase. So this is no need for anion gap. Anion gap is only in metabolic acidosis because only metabolic acidosis influences the anion change. You go up to this. This is pretty acidic, and this is basic, and this is acidic. So this is probably causing the problem. So this is metabolic acidosis. Next step would be to calculate anion gap to check the underlying etiology. And you can also do the equation to see the metabolic acidosis equation, 10 bicarb, to see if this is enough compensation or no. But I solved it on my own to check for you. So yes, it is compensated. I remember it was 23 or something. So it's almost compensated. His lungs are doing fine. So yeah, this is pretty much how you solve it. Like with my explanation, you can just apply and you will be fine. It's very simple to solve, by the way. But for the exam, it's unlikely to solve such solutions. Step one, you will never solve anything. I'll show you some questions. You will only just identify. So let's take some examples. First of all, any questions before I ask you my questions? No questions? Now it's my turn. I will wait 1 minute. No questions. Okay. No. Okay, two more questions and we're done, inshallah. Or a few more questions. So this is a 36-year-old man, emergency department, confusion, nausea, unable to answer, blah, blah, blah. We don't care. Let's check the labs. pH, 7.25, low or high? Speed run. Speed run. Low, acid. So let's move to the next step. PaCO2, what is this? Low or high? Low, so it's acid or base. Alkalotic. So is it the problem? No, it's not corresponding with pH. Let's go to bicarbonate. Bicarbonate is low. Bicarbonate is low. So what's this? Acidic or alkalotic? Low. Acidic. Acid, yes. So who's causing the problem? Bicarbonate or PCO2? Yes, it's acidosis. Yes, yes, yes. It's acidosis. What acidosis is it? Metabolic or respiratory? Metabolic. So we have here, we have Hagma and Nagba. Okay, let's check. Let's do a quick calculation. 136 minus 90 plus 12. So 90 plus 12 is what? 102, right? Now 136 minus 102, that's 24. That's high anion gap. Do you agree? Yeah, yeah, yeah. Agree. That's it. Easy. This is step one, by the way. This is your world. Easy. See? Straightforward. You check pH. Who's causing the problem? Check the choices and then answer. Easy. Let's go to the next one. 64-year-old man, blah, blah, blah. He has blood pressure high, pulses, and he has some edema. That's too bad. Okay, so he has, we can see that he has CKD because he has edema, crackles, basically, and creatinine is high, BUN is high. So this looks like chronic kidney disease, right? So you would expect some type of acidosis in chronic kidney disease because what did we say about the kidney? This is a bit advanced. Kidney, they're supposed to secrete hydrogen. Okay? But if they're not secreting hydrogen and they're failing, acidic. So let's check the acidosis. This is acidic. This is acidic. Acidic. A and C and D are acidic also. They're a little bit acidic. Let's check the bicarbonate. So you will expect, yes, you said A and B because they are too low, right? Because they are low. You already, mashallah, check the next step. Next step is to check the bicarbonate. Oh, A and B are very low. And C, by the way, C is low. So it's ABC because it's metabolic acidosis. Let's check the PCO2. Now, in a normal patient, you expect the PCO2 to be low or high when he has acidosis. What will the lungs do to compensate? Low. So let's check the low. 48, that's high. 37, that's high. 28, that's low. Let's go. Immediately choose what? B. Easy, right? Very easy. You just check the numbers and you choose. I think this is the final question. Oh, sorry. 50-year-old man, hospital, he has something bad, obesity, whatever. My brother, what do you have? Okay, sodium, chloride, bicarbonate. So he gave you some values here. Bicarb is low. So that's acidosis. Let's check, is it Hagma or Nagma? 138. First of all, add these two. So 110 plus 18, that's 128, right? 138 minus 128, that's 10. Is 10 Nagma or Hagma? It's 8 to 12, so it's normal. 8 to 12 is normal. Normal. So it's none. Yes, it's non-anion gap. So non-ion gap. Lactic acidosis or diabetic acidosis, what do these cause? Oh, they're not. Yeah, it's Hagma. It's Hagma. Obesity, hypoventilation, this is respiratory, so forget it. Primary hyperaldosterone, what is aldosterone? Aldosterone causes alkalosis, not acidosis, so it's not it. So it's probably what? It's probably E. Yes, because these two are Hagma, this is respiratory, and this is alkalosis. And here it's metabolic acidosis. Very easy, guys. This is also a bit advanced. I don't think you'll get it. That was it for my part. اللهم إني أستودعك ما قرأت وما حفظت وما تعلمت فرده لي حاجة إليه إنك على كل شيء قدير. This is a beautiful prayer. After you finish studying, you basically ask God to give you the information that you learned and make sure it's stuck to your brain, and that when you need it, it comes back to you immediately. This is a bit, not very accurate translation, but it's a very beautiful dua to do after each study session or lecture. So, any questions? No, if no questions, please scan the QR code for feedback. I hope that was clear, and I most importantly hope that those two lectures, the devils of nephrology, are covered. And now I did my promise. I did as promised. I promised that you will have an exceptional understanding of those concepts, and I hope that promise is delivered. That mission is accomplished. This is my primary mission. So, Alhamdulillah, I hope your exam is easy. Regarding, as I told you, regarding electrolytes and acid base, the doctor will not put questions that are crazy. Okay, it's gonna be like very easy or maybe little questions. What you need to focus on is pathology. Pathology for renal is very important. Okay, like Dr. Abrar's lectures. If he's still teaching you, I think he's still there. So very important. Nephrotic, nephritic. Those stuff are more high yield than acid base or electrolytes for your renal block. What I taught you is also very important, inshallah. If you want IM, it will be useful. If you want to do steps or any board exams, inshallah, it will cover pretty well. Alhamdulillah. And I wish you all the best of luck.